Good evening, Dr. Phil here. Today we'll be discussing on one-lung ventilation. Indications for one-lung ventilation. Protection of the good lung from contralateral pathology such as blood during endobronchial hemorrhage and pus from empyema or lung abscess. Independent ventilation of each lung may be needed due to conditions such as large bronchopleural fistula, bronchocutaneous fistula, unilateral bulla, tracheobronchial trauma, marked different compliance of two lungs, such as during split lung ventilation in ICU, etc. Bronchopulmonary alveolar lavage to treat conditions such as pulmonary alveolar proteinosis, where only one lung is to be lavaged with liquid at a time, while the other is protected. Collapse of one lung to allow surgical access to other structures, such as open pulmonary surgery, pneumonectomy, lobectomy, open pleural surgery, video-assisted pulmonary or pleural surgery, esophageal surgery, spine surgery, thoracic aortic surgery such as thoracic aneurysm, transthoracic cervical sympathectomy, pleurodesis, etc. Options for one-lung ventilation. The double lumen tube. DLTs are specialized tubes to allow isolation of a lung and single lung ventilation. Advantages. It has the greatest flexibility compared to other methods of OLV. It allows changes easily from ventilation of two lungs to one lung, then back to two lungs during or at the end of surgery. It allows aspiration of the main bronchi independently. Insufflation of oxygen to the non-ventilated lung can be performed. It isolates the lung from contralateral pathology and allows CPAP to be applied to the non-ventilated lung. Disadvantages of DLTs. It is challenging to insert and position correctly as it is bulky. DLT have larger external diameters than bronchial blockers or bronchial tubes. It may be more difficult to position correctly, especially if tracheal or bronchial anatomy is distorted, such as by a tumor or effusion. It is more complicated to insert than single lumen tubes and require rotation within the airway of between 90 to 180 degrees. It is prone to becoming malpositioned during patient positioning or surgery. Problems with double lumen tubes were implicated in 30% of perioperative deaths during the NCE-POD 1998. Critical malpositioning occurs in more than 25% of cases. General misplacements complicate more than 80% of users. DLTs are too large for children less than 8 years old. There is high resistance to spontaneous ventilation as two separate lumens are narrow. Overcome this by positive pressure ventilation. A single lumen tube may have to be substituted at the end of surgery if resumption of spontaneous ventilation is not immediate. Complications. Failure to achieve adequate lung separation and one lung ventilation, prolonged surgical retraction and associated pulmonary trauma, occlusion of a main bronchus with lobar collapse and secondary infection, contamination of the dependent lung by infected secretions from the upper lung and trauma during insertion. Different designs of the DLT. Carlen's DLT has a carinal hook to aid bronchial placement. The carinal hook makes intubation of the glottis difficult. Robert Shaw DLT is originally made with red rubber, which makes it reusable. A stylet is supplied to make the tube more rigid and easier to manipulate. Mallinckrodt bronchocath double lumen tube. It is a disposable clear PVC version based on the Robert Shaw design. Left and right versions exist to adapt to the differing anatomy of the main bronchi and their branches. Left DLT are preferred even for right side surgery as the right main bronchus is shorter than the left, 2.5 cm. The bronchial cuff of a right DLT may obstruct the origin of the right upper lobe easily, and this is undesirable. Right-sided DLT has a Murphy eye with a shaped or slotted bronchial cuff to ventilate the right upper lobe, and it is easily malpositioned and fine positioning is necessary. There is no Murphy eye in the left-sided version, because the distance between the carina and left upper lobe bronchus is about 5 cm, which is adequate to place the cuff. Components of a Mallinckrodt bronchocath double lumen tube. It has two separate color-coded lumens, each with its own bevel. One lumen ends in the trachea, the other lumen ends in either the left or right main bronchus. There are two cuffs, the tracheal and bronchial cuff. Each lumen has its own cuff. Lumens and pilot balloons are color-coded and labeled. There are two curves, the standard anterior curve to fit the oropharyngeal, laryngeal, tracheal airway. The second curve to the right or left to fit into the right or left bronchus respectively. There is a Y-shaped catheter mount at the proximal end of these tubes and attaches to the breathing system. Sizes available: 28 to 41 French. It comes in different sizes to fit adult patients but not in pediatric sizes. Mechanism of action. Consider this correctly positioned left-sided DLT. Both cuffs are inflated. The bronchial cuff is in the left main bronchus. The tracheal cuff is in the trachea. Ventilation of the bronchial lumen ventilates only the left lung, and ventilation of the tracheal lumen ventilates only the right lung. Collapsing the lung. If the chest is open and either lumen is left open to air, its respective lung will collapse to facilitate surgical access. Positioning the DLT. A double lumen tube is positioned correctly when the upper surface of the bronchial cuff lies immediately distal to the bifurcation of the carina. The tube position should therefore be checked using a fiber optic bronchoscope. Clinical assessment of DLT position is unreliable. Auscultation of the lung fields during clamping and release can be performed. Auscultation findings may be equivocal if access to the chest wall is limited because surgery has begun. Oximetry and capnography are not specific in indicating where the DLT is sited. Fiber optic bronchoscope should be used to check DLT position. The average depth of insertion for a patient height of 170 cm is 29 cm at the level of incisors. This distance alters by 1 cm for every 10 cm change in height. Classic DLT insertion technique and clinical assessment of DLT position. Recommended sizes for typical adults: adult men 37 to 41 Fg, adult women 35 to 37 Fg. Patient position should be supine, on level operating table, head supported with a single pillow, shoulders clear of the pillow, flex the neck and extend the head. Ensure connection to the breathing system is present. Stylet is appropriately curved. Exaggerating the bronchial curve is useful. Induction of anesthesia, muscle relaxation and laryngoscopy. Intubation. Intubate the larynx with the bronchial curve angled anteriorly. Remove the stylet once the tip of the DLT passes through between the vocal cords to avoid airway trauma during rotation of DLT. Rotate 90 degrees towards the desired bronchus. The head is turned away from the side of the bronchial lumen. Advance DLT until resistance is felt and the bronchial tube is thought to be in the correct position. Connect the DLT to breathing system and inflate the tracheal cuff. A correctly positioned DLT should function like a standard single lumen ETT and ventilate both lungs if only the tracheal cuff is inflated. The following signs help indicate that both lungs are being ventilated: visible movement of both sides of the chest, detection of a recognizable trace of exhaled carbon dioxide, breath sounds auscultated in both axilla, unchanging pulse oximeter reading. Checking the position of DLT. Clamp the tracheal lumen and open the tracheal cap. A whoosh of air should escape from the lungs as it empties through the tracheal lumen. Ventilate the bronchial lumen. A leak will be present through the tracheal lumen. Inflate the bronchial cuff with 2 mils of air. The leak through the tracheal lumen should stop if the cuff is correctly placed. Check that the correct lung is able to be ventilated. Unclamp the tracheal lumen and clamp the bronchial lumen and open the bronchial cap. Check that the opposite lung is ventilated only via the tracheal lumen. Malposition DLTs. In this diagram, the bronchial lumen is in the trachea, lung isolation is impossible, insert the DLT further or choose a larger size. In this diagram, the bronchial cuff herniates proximally so the cuff covers the other bronchus. Unable to ventilate the lung via the tracheal lumen, insert the DLT deeper. This diagram shows that the upper lobe occlusion by the right-sided DLT bronchial cuff. Manipulate the tube position so that the Murphy eye is correctly placed. Changes in airway pressure during volume-controlled ventilation. Increased airway pressure occurs during breathing cycle when the tidal volume is directed down one lung when each lumen of the DLT is clamped. If there is no change in airway pressure, the bronchial lumen is likely to end in the trachea, or else there is a substantial leak past the bronchial cuff. The correctly placed double lumen bronchial tube is then secured with a tracheostomy tape at the teeth by a clove hitch. The tube tie is knotted around the neck by a bow to enable its release quickly when required. The position of the DLT should always be rechecked after the patient has been subjected to any changes in position, such as from supine to lateral. Clinical testing of the position of the DLT is specific but not sensitive. A sign indicating malposition of the DLT is likely to predict a real malposition. After apparently successful positioning of the tube, inadequate isolation of one lung and excessive airway pressures may be encountered. Correct alignment of the fenestration in the bronchial cuff over the origin of the right upper lobe bronchus is difficult to predict by clinical means alone. Use fiber optic bronchoscopy instead. Bronchoscopy to confirm DLT position after a classical DLT insertion. Use a narrow diameter 2.8 mm bronchoscope to confirm DLT position. Pass a suction catheter down the bronchial lumen to remove secretions if necessary prior to bronchoscopy. Lubrication of the bronchoscope with water-soluble jelly eases its passage through the lumens of the DLT. Insert the bronchoscope through the tracheal lumen. The carina should be visible beyond the end of the DLT. A rim of bronchial cuff should be visible in the appropriate bronchus, left for left-sided DLT and right for right-sided DLT. Then insert the bronchoscope through the bronchial lumen. The upper lobe bronchus should be just visible beyond the end of the tube. Irrigation fluid aspirated through the suction port helps to prevent it from being blocked by encrusted aspirate. Positioning the DLT using fiber optic intubating bronchoscope. The DLT is passed between the vocal cords during laryngoscopy and advanced further with the fiber optic bronchoscope passed within the bronchial lumen. The blue bronchial cuff occludes side of the orifice of the right upper lobe bronchus until the side hole in the bronchial cuff lies over it. Visualizing the bronchial rings of the right upper lobe bronchus confirms the correct position of the bronchial tube. Inflate the bronchial cuff with 2 mL of air. Uninterrupted side of the right upper lobe bronchus confirms that the side hole of the bronchial tube relative to the bronchus is maintained in a correct position. The bronchi to the right middle and lower lobe may be seen through the distal lumen of the bronchial tube. It is common to have the tip of the bronchial tube covering the orifice of the right upper lobe bronchus after DLT insertion. Anchoring the DLT. The double lumen tube is then held against the teeth or gums of the maxilla. The mark on the tube there is noted. The fiber optic scope is removed from the bronchial lumen. The DLT is tied with a clove hitch over this mark and the tube tied tight around the neck with a bow. The tracheal cuff is then inflated with 5 mL of air and the fiber optic bronchoscope is passed down the tracheal lumen until the carina is identified again. The bronchial lumen is seen to pass down the correct main bronchus and the bronchial cuff in its main bronchus is seen to be inflated but not herniating to impinge over the lumen of the other main bronchus. The bronchoscope is then removed from the tracheal lumen and both lungs are ventilated. Bronchial and tracheal lumens are clamped in turn, observing airway pressures, leaks, and the extent of ventilation of each lung. The second option is a bronchial blocker. It is an alternative means to the DLT to provide OLV. Advantages: it allows lung isolation in children or adults where a DLT would not fit. No ETT change is required at the end of the case. A single lobe can be isolated. Less airway trauma than a DLT. Disadvantages: it is difficult to position. prone to be dislodged. The lung is slow to deflate as the blocker has a narrow lumen. The deflated lung unit can't be suctioned. The endobronchial blocker cannot be repositioned once the wire loop has been removed. Components: Iron endobronchial blocker set. The blocker catheter has a diameter of 9 French, length 78 cm, distal cuff, pilot balloon, guide loop emerges from its tip. There is a multi-port adapter. Rouge bronchial blocker. The blocker catheter has a hollow lumen and allows insufflation of oxygen and some suctioning. It may be used with a jet ventilator which overcomes some of the disadvantages of the technique. It is 170 cm long. There is a 2 mm outside diameter. The balloon is 2.75 mm diameter and accepts 5 mL of air. It can be passed down a bronchoscope with a lumen of more than 2.8 mm diameter or through a 15 mm tapered connector with a 1.8 mm seal. Fogarty embolectomy catheter has been used as a bronchial blocker. It has a 3 mm balloon. Mechanism of action. The patient is intubated with a standard endotracheal tube. A multi-port adapter is connected to the endotracheal tube's 15 mm connector. The tip of a fiber optic bronchoscope is placed through the guide loop of the bronchial blocker and passed through the multi-port adapter. Ventilation can still be maintained while positioning the bronchial blocker. The bronchoscope is positioned in the bronchus. The blocker is advanced off the end of the bronchoscope. When the blocker's position is satisfactory, balloon inflation under bronchoscopic vision takes place and the desired main bronchus is sealed. The wire loop is removed. Ventilation of the contralateral lung is maintained via the tracheal tube. Physiological changes during OLV. During one lung ventilation, the surgical site is uppermost and the non-ventilated upper lung is described as the non-dependent lung. Shunt occurs, which is perfusion without ventilation. In the non-ventilated lung, blood flowing through it does not take part in gas exchange. Ventilation perfusion mismatch and a shunt occurs, which contributes to hypoxia. Increasing FiO2 does not improve hypoxemia caused by right to left shunt. Hemoglobin is fully saturated at the flat portion of the oxygen dissociation curve. A further increase in alveolar oxygen tension results in only a small increase in oxygen content in solution. Increasing FiO2 has no effect on the oxygenation of the blood in the non-ventilated lung. Increasing alveolar ventilation of the ventilated lung decreases arterial carbon dioxide tension. Gradient from arterial to alveolar partial pressure of carbon dioxide is smaller than that for oxygen due to the greater solubility of carbon dioxide and its more linear dissociation curve. Change in arterial oxygen tension is not significant. Mechanisms that decrease shunting. Gravity. Gravity favors blood flow to the dependent ventilated lung. Surgical compression and retraction decreases blood flow to the non-ventilated lung. Surgical ligation of blood vessels in the non-ventilated lung. Shunt will largely disappear if the pulmonary artery is clamped prior to pneumonectomy. Hypoxic pulmonary vasoconstriction is a mechanism that diverts blood flow away from areas of the lung where the alveolar oxygen tension is low, shunting it to better ventilated zones and improving the VQ ratio. Elsewhere in the circulatory system, hypoxia always results in vasodilation of vascular beds. Benefits of HPV. There is a decreased blood flow to the non-dependent lung by up to 50% and decreased shunt from 50 to 30%. HPV has no effect if the alveolar oxygen tension is either 100% or 0%. The alveolar oxygen tension is the same throughout all lung units. Increased pulmonary vascular resistance due to high peak and end expiratory ventilation pressures in the dependent lung overcome any benefits of HPV in the non-ventilated lung. Increased alveolar pressures results in increased dead space by producing a region of lung which is ventilated but not perfused. Inhibition of HPV by volatile anesthetics and pulmonary vasodilators such as glyceryl trinitrate sodium nitroprusside, isoprenaline, dobutamine, and nitric oxide. HPV is more likely to have an effect with the 20 to 30% of cardiac output shunting through the non-ventilated lung during OLV. When pulmonary artery pressures and mixed venous oxygen saturation tensions are normal, HPV effects are maximal. An abnormally low mixed venous oxygen tension caused by low cardiac output or high oxygen consumption has a greater influence than any changes possible with HPV, such as during hyperthermia or shivering. There are other more important causes of hypoxemia than reduced HPV, such as poor positioning of the patient, which compromises blood flow to the dependent lung, malposition of the double lumen bronchial tube, low cardiac output caused by inadequate blood volume replacement, impediment of blood flow by surgical manipulation, etc. The dependent lung loses volume due to compression. HPV may compensate partially by diverting some blood flow to the non-dependent lung. Pooling of secretions occurs in the dependent lung. Suction to remove secretions via a double lumen tube may be very difficult. Pulmonary vascular resistance. To avoid hypoxemia, maximize PVR in the operative lung and minimize PVR in the dependent lung. In general, PVR is lowest at FRC. PVR increases hyperbolically as volumes deviate in either direction from FRC. FRC occurs at a slightly lower than normal volumes during OLV due to paralysis, lateral positioning, open operative hemithorax, and weight of mediastinal structures. Consequences of a surgical thoracotomy wound on respiratory mechanics. Respiratory compromise occurs when a patient breathes spontaneously through a surgical thoracotomy, with effects similar as trauma patients with a large open chest wound. The negative pressure of the pleural space is lost when it is open to the atmosphere. Paradoxical ventilation of the lung occurs. During inspiration, gas flows from trachea and lung in the non-dependent lung to the dependent lung, and during expiration, gas flows from the trachea and lung in the dependent lung to the non-dependent lung. The lung in the open chest inflates. Gas is transferred from lung to lung. There is increased PaCO2 as CO2 is not expelled, and decreased PaO2 as gas inspired into the dependent lung is hypoxic. Methods to halt this paradoxical ventilation: occlusive dressing over the chest, or isolation of the lung in the open chest with a blocker or double lumen tube. Ventilator settings in one lung ventilation. To avoid hypoxemia, maximize PVR in the operative lung and minimize PVR in the dependent lung. Ensure correct positioning of the DLT. Bilateral lung ventilation continued for as long as possible prior to OLV. Many anesthetists use FiO2 of 80 to 100%, although shunt is not substantially improved by supplementary oxygen. Pros of high FiO2: it provides a margin of safety to have a high PaO2 of 150 to 200 mm mercury and to dilate pulmonary vessels, especially in the ventilated dependent lung. Cons of high FiO2: there is potential for absorption atelectasis. Counteract this with application of PEEP. High FiO2 can induce pulmonary oxygen toxicity and ARDS, especially in patients receiving bleomycin. FiO2 as low as 0.25 to 0.5 should be used, and this generates a PaO2 of 62 to 87 mm mercury. High FiO2 may increase the requirements of volatile anesthetics and increase their adverse effects such as hypotension. SpO2 target. Most practitioners aim to maintain 90% or higher, which is equivalent to PaO2 of 60 mm mercury. Adjust as needed based on comorbidities such as coronary artery disease, cerebrovascular disease, anemia, etc. There are no evidence-based recommendations regarding the lower limit of acceptable SpO2. The incidence of hypoxemia during OLV has decreased over the years. Tidal volume. 10 to 12 mL per kg is recommended. Every patient has their own optimal ventilatory settings in OLV, and it takes time and effort to discover these. Tidal volume of less than 8 mL per kg ideal body weight can result in dependent lung atelectasis and reduced FRC. Thus, tidal volume of 10 to 12 mL per kg is recommended. Tidal volumes of more than 15 mL per kg increases pulmonary vascular resistance in the dependent lung and increased shunting of blood to the operative lung. Ventilator settings are similar to those used for double lung ventilation. Higher TV increases mean airway pressures, increased vascular resistance, increased blood flow to the non-ventilated lung, and increased shunt. Lower tidal volume increases pulmonary atelectasis. Respiratory rate should be titrated to keep EtCO2 at around 40 mm mercury, which is approximately PaCO2 of 35 mm mercury, as hypocapnia inhibits hypoxic pulmonary vasoconstriction. PEEP, pros: increase FRC in the dependent lung, improves VQ ratio, increase oxygenation, and decrease atelectasis. PEEP can be applied while surgery is ongoing. Cons: mixed results from studies regarding the benefits of PEEP. There is increased pulmonary vascular resistance, and this diverts blood to the non-ventilated upper lung. Application: 5 to 10 cm H2O in small increments. Auto-PEEP occurs in emphysematous lung, elderly patients, small DLT lumen, bronchospasm, etc. Pros: beneficial if auto-PEEP moves the patient towards FRC on the compliance curve, which rarely occurs. It is more commonly to have auto-PEEP to move the patient away from FRC. Management of auto-PEEP: decrease tidal volume and increase expiratory time. P plateau should be less than 25 cm H2O. CPAP applied to the non-dependent lung. It is the most effective method to increase PaO2. It must be preceded by a recruitment maneuver. Opening pressure of an atelectatic lung region is more than 20 cm H2O. Amount of CPAP required is minimum 1 to 2 cm H2O for fully inflated lungs, or 5 to 10 cm H2O immediately after an inspiratory breath. If it is more than 10 cm H2O, this can cause over-distension and/or hemodynamic consequences such as increased PVR. An alternative to CPAP is oxygen insufficiency of the non-dependent lung. Lung recruitment to immediately treat atelectasis in the dependent lung. Increase PIP to 40 cm H2O with a PEEP of 20 cm H2O for 10 consecutive breaths. This increases PaO2 to 244 mm mercury as compared to 144 mm mercury in patients who did not get the recruitment maneuver, based on a study by Tusman et al. PaO2 decreases during the initial 45 minutes of OLV. Frequent ABGs may be required during this initial period. Benefits of pressure control over volume control mode. There is decreased peak airway pressures, decreased plateau pressures, decreased incidence of sudden airway pressure changes due to surgical manipulation. There is decreased pulmonary shunt and better outcomes in patients with COPD, underlying pneumonectomy, and lung transplant. There are no differences in cardiac output or oxygen saturations. Managing hypoxia during OLV. Risk factors for desaturation during one lung ventilation includes very high or low VQ ratio, normal spirometry, restrictive lung disease and/or severity of COPD, cardiac disease, supine positioning, right-sided thoracotomy. Hypoxia with two-lung ventilation is the most predictive. Check the FiO2, increase it to 1.0. Check the tidal volume and other ventilatory indices. Refer section on ventilator settings in OLV. Avoid hypocapnia, which may decrease HPV, increase tidal volume. Suction down the lumen. Check the position of the DLT by fiber optic bronchoscopy. Apply CPAP of 5 to 10 cm H2O to the non-dependent upper lung. Warn the surgeon that the lung may partially re-expand. In video-assisted thoracic surgery cases, avoid CPAP where it is disruptive. PEEP of 10 cm H2O can be tried in the dependent lung in BATS cases. Increase CPAP in small increments. This diagram shows a bronchocath double lumen tube with bronchial lumen connected to a CPAP valve assembly. The disconnected limb of the Y-shaped catheter mount is clamped. Oxygen insufficiency of the non-dependent lung is an alternative to CPAP. PEEP of 5 to 10 cm H2O can be added to the dependent lung. This increases lung volume in atelectatic areas and may increase PVR and divert blood to the non-dependent lung. Increase PEEP in small increments until the PaO2 target is achieved. If none of the above treated the hypoxia, Try intermittent inflation or double lung ventilation. Surgery may be continued with lung retraction. Maintain cardiac output and pulmonary artery pressures near normal range. Surgical clamping of the pulmonary artery obliterates the shunt. Returning to 2-lung ventilation after 1-lung ventilation. Suction the non-ventilated lung to clear pus or blood. Using the long suction catheter supplied with the DLT, close the sealing cap on the lumen to the non-ventilated lung. Remove the clamp on the Y connector and switch to manual ventilation. Re-inflate the collapsed lung under direct vision. Long sustained ventilation breaths are effective. Inflation pressures of up to 35 to 40 cm H2O are often required to fully re-expand all areas of the lung. The surgeon observes for air leaks during re-inflation of the collapsed lung and may ask for a specific airway pressure to be generated. Switch back to mechanical ventilation. Return to the original 2-lung ventilator settings and FiO2 unless significant volumes of lung has been resected. Adjust minute ventilation to achieve normal capnia. Return to OLV may be necessary should complications occur such as large air leak from operated lung. Deflate the bronchial cuff as soon as possible to prevent bronchial wall necrosis. These are my references. Thank you.